Good morning, respected judges. Thank you for selecting us as the finalists for URIC. I'm Saima Mohammed.
I'm Mahi Nasser.
I'm Simra Bhatt.
And I'm Umehani Bandukwala, and we're students from Gulf Medical University. We're honored to present our research titled The Prevalence, Factors, and Impact of Premenstrual Syndrome and Premenstrual Dysphoric Disorder Among Adult Women in the UAE.
This slide outlines the structure of our presentation. Now I'm going to give you a brief introduction to provide some context for our study. Up to 80 to 90% of women worldwide experience at least one premenstrual symptom. But when do these symptoms become severe enough to be considered a disorder? This brings us to two very common conditions called PMS and PMDD. So what exactly is the difference between PMS and PMDD? Premenstrual syndrome, or PMS, refers to a combination of physical and emotional symptoms that occur 1 to 2 weeks before menstruation and affects nearly half of women globally and around 35% of women in the UAE. On the more severe end of the spectrum, we have PMDD, or premenstrual dysphoric disorder, and it is a clinically recognized condition in the DSM-5 and affects approximately 2 to 8% of women worldwide. But unlike PMS, PMDD is associated with significant distress, impairment in daily functioning. Both conditions are influenced by a complex interplay of factors, including hormonal fluctuations, stress, diet, sleep. Some common symptoms such as mood swings, anxiety, fatigue, difficulty concentrating can significantly impact daily life, relationships, or academic or work performance. Now, some existing literature highlights the premenstrual disorders exist on a spectrum ranging from milder symptoms to more severe, functionally impairing conditions. Globally, PMS affects approximately 47.8% of women, while PMDD affects around 2 to 8% of women. But in the UAE, the population affected by PMS is 35%, and the population affected by PMDD is 16 to 18%. And again, these conditions are influenced by a combination of biological and lifestyle factors, including hormonal fluctuations, sleep disturbances, diet, smoking, and physical activity. Psychological symptoms such as anxiety, depression, irritability, and mood swings are quite common with PMDD, associated with more severe effects. Overall, these symptoms significantly impact quality of life, affecting academic performance and mental health. However, despite this impact, there is limited region-specific research in the UAE, highlighting the need for further studies to better understand these conditions and guide targeted interventions. Given the limited region-specific research, there is a clear need to better understand the burden of premenstrual disorders in the population. So our study aims to bridge the gap by investigating different aspects of PMS and PMDD, and most UAE studies focus on prevalence only, with limited exploration of predictors and quality of life impact. And we're also focusing on influences such as smoking, diet, and lifestyle. This research highlights the need for culturally relevant diagnostic and management strategies, and findings will guide the development of screening tools, awareness campaigns, and tailored interventions aiming to improve women's health and quality of life.
Now we're going to talk about the materials and methods of our study. The research design is a cross-sectional study design. We included women aged 18 to 50-year-old who experienced regular menstrual cycles for at least the past 6 months. These are women regardless of any nationality who provided informed consent. We decided to exclude women who were undergoing menopause, who were using hormonal contraceptives, pregnant women, and women who were with chronic gynecological conditions. We also decided to exclude individuals with current or severe psychiatric disorders, as these are confounding variables and would have affected the accuracy of our PMS and PMDD symptoms. Calculated minimum sample size included 601 participants. This was to account for any incomplete responses and to improve the reliability of our results. Our study settings was conducted across multiple locations within the UAE. We recruited target participants by approaching Thumbay networks, hospitals, clinics, and various public places. This was to acquire a more diverse set of participants. We completed the study over the course of 9 months. How did we conduct the study? We approached eligible women who consented to participate. We got them the consent form to sign and provided them with the questionnaires to complete. The questionnaires were all self-administered, with the researchers present to address any concerns or questions they might have. And for participants who could not read and write in English, we conducted an interviewer-administered questionnaire. The data collection tools that we used in our study included 2 standardized questionnaires and 1 researcher-developed questionnaire. The 2 standardized questionnaire included the PSST, which is also known as the Premenstrual Symptom Screening Tool, for which the copyright was obtained from McMaster University. The second standardized questionnaire was the WHO Quality of Life Brief questionnaire. Our researcher-developed questionnaire was designed to explore the associated factors. We had this questionnaire validated via 3 experts, and it underwent pilot testing. The questionnaire was anonymous, confidentiality was maintained, and informed consent was obtained. The questions were phased sensitively, and access to the data was restricted, with the exception of our research team and the members of the IRB. We analyzed the data using SPSS, employing descriptive statistics for data presentation and inferential methods such as the chi-square test and the t-test for associations and logistic regression for predictor analysis.
Now we're moving on to the results section. All of our data was analyzed using IBM SPSS statistics. This slide summarizes the socio-demographic characteristics of our participants. As you can see, most of them fall under the 18 to 24 age group, were normal BMI, and were single. Figure 2 demonstrates the prevalence of mild and moderate to severe PMS. As you can see, the prevalence of moderate to severe PMS was substantial with a 40%. This demonstrates a high burden of PMS, whereas our figure 3 depicts the prevalence of PMDD, which was comparatively smaller with 11.7%, but clinically significant. Now, here is a graph that depicts the prevalence of PMS symptoms across different severity levels. As you can see, most of our participants reported symptoms to be in the mild to moderate category. However, there was a notable amount that also experienced severe symptoms, especially in the category of fatigue and physical pains. Chi-square test was done to assess the different factors associated with PMS, and significant associations were found with PMS and family history, sleep habits, physical activity, smoking habits, BMI, diet, consumption of processed or fast food, coffee consumption, extra salt consumption, history of mental health conditions, stress in daily life, and experience of traumatic event. Similarly, PMDD was found to be significantly associated with nationality, particularly the African region, physical activity, smoking habits, BMI, diet, extra salt consumption, family history, history of mental health conditions, stress in daily life, and experience of traumatic event. Moving on to the binary logistic regression, which was done to analyze the independent factors associated with PMS and PMDD after controlling for co-founders. Adjusted odds ratios were also calculated. Significant predictors included family history, extra salt consumption, physical activity, and history of mental health conditions, all of which increased the likelihood of developing moderate to severe PMS by almost 2 times, whereas smoking habits increased the likelihood by 3.4 times, stress in daily life by 1.5, and history of trauma by 1.8 times. In the case of PMDD, family history, stress in daily life, and history of trauma were found to be independent predictors. Normality of quality of life scores was assessed using histogram and Shapiro-Wilk test. As the data was found to be not normally distributed, Mann-Whitney-U test was performed to compare the groups, which included physical, psychological, social, and environmental. A statistically significant difference was found across all 4 domains. The participants who experienced moderate severe PMS had lower scores as compared to those who had mild symptoms. Also, the participants who suffered with PMDD had much lower scores as compared to those who did not have PMDD.
Okay, so moving on to the discussion. Our study found a PMS prevalence of being 40% and PMDD being 11.7% among adult women in the UAE. These estimates are comparable to a recent study based in the UAE where the PMS was reported to be 35.3% and while all the participants also reported at least one premenstrual symptom. In contrast, higher prevalence rates have been observed in Saudi Arabia where the PMS is 72.9% and Egypt being 77.7% and PMDD being 40%. Moreover, even in Jordan, the PMS prevalence was reported to be 72.9%, PMDD 34.7%, and in Ethiopia 33.3%. These higher rates may be due to the broader participant demographic. Okay, moving on to the associated factors. Age, marital status, education, and employment were not significantly associated with PMS and PMDD in our study. However, overweight and obese women experienced greater PMS symptoms, supporting findings from the US, India, and Saudi Arabia. Women with a family history of PMS and PMDD were about twice as likely to experience PMS symptoms, supporting studies from India, China, and South Korea, and the US. Poor sleep quality also resulted in an increased PMS severity consistent with studies in South Korea and the US. However, physical activity paradoxically revealed that moderately active women showed higher PMS rates due to reverse causality or differences in the type or the intensity of the activity, also seen in studies in India and Hungary. This could be likely because of women that already have PMS engaging in more physical activity as a coping mechanism to manage their symptoms. Okay, continuing with the factors associated, smoking emerged as a very strong predictor of both PMS and PMDD, consistent with findings in Spain, US, and South Korea. In contrast, alcohol consumption showed no significant association, likely reflecting cultural factors and low consumption levels in the UAE. High salt intake, though, was positively associated with both PMS and PMDD, in agreement with studies from Vietnam and India. Consumption of fast food was found to decrease PMS, though, and did not affect PMDD. This inverse association was observed only in our study. This could be due to reverse causality, reporting bias, or unmeasured confounding. Overweight and obese women experience greater PMS symptoms, supporting findings from India and Saudi Arabia. Okay, now the psychological factors. So mental health history was associated with a 2 times increased risk of PMS, also consistent with studies in the US, UAE, and Brazil. History of trauma, furthermore, was associated with a 4-fold increased risk of PMS and a 2.5-fold increased risk of PMDD, in line with the findings reported with China. Higher stress levels was associated with a 1.5-fold increase in PMS and a 2 times increased risk for PMDD. So PMS and PMDD was associated with reduced WHO-QOL brief scores across all the domains. Physical and psychological quality of life was significantly impaired, consistent with studies from the UAE, Ethiopia, and Iran. Similar findings of physical and psychological impairment were also reported in UAE and Ethiopia. Moving on to the strengths and limitations of our study. So this study presents several key strengths while also acknowledging certain limitations. The study included a large and diverse sample, the sample being 667 participants. We also used validated tools like PSST and WHO-QOL brief. They were used to ensure reliable measurement. Additionally, multivariable logistic regression analysis allowed for adjustment for potential confounders. Limitations. The cross-sectional design restricts causal inference. Data were self-reported and therefore may be subject to bias. Furthermore, the use of convenience sampling may limit generalizability of the finding. To conclude, PMS and PMDD were found to be highly prevalent among women of the reproductive age in the UAE, with nearly half experiencing moderate to severe symptoms of PMS and approximately 10% meeting the criteria for PMDD. Key associated factors included poor sleep quality, smoking, a higher BMI, and an increased intake of caffeine and salt. Psychological factors such as stress, past trauma, and prior mental health conditions were also strongly associated with an increased risk and severity. Both PMS and PMDD were shown to significantly impair the quality of life across physical, psychological, social, and environmental domains, with notable effects on productivity, relationships, and the emotional well-being. We would like to thank all the women who contributed to our study and participated in our research. Future research research should aim to inform the development of nationwide educational initiatives focusing on modifiable risk factors for PMS and PMDD. Efforts should also be directed towards educating women on a healthy lifestyle practices, including balanced nutrition and the reduction of salt and caffeine intake. Furthermore, increasing the public awareness is essential to support the development of policies that promote women's well-being throughout their menstrual cycle. Thank you so much.